Hello, coders. Good morning, good evening, good afternoon, all depending upon where you're joining us from. First of all, let me know in the chat, how do I sound? Am I audible? Are you able to hear me? All right, let me know in the chat, coders. So, welcome back to the CPT Guideline Mastery session. Thank you for letting me know. So, welcome back, everyone, to the CPT Guideline Mastery session with AMCI. So it's so great to see you all back here. And I'm excited to jump back into the learning as well with you all as we continue to strengthen our understanding of the CPT guidelines and how they truly drive to the accurate coding. So these sessions are all about breaking the things down, clearing up confusions, and building confidence one guideline at a time. So today we will stay interactive, walk through the real guideline concept. So get comfortable, everyone, stay engaged, and let's make this a productive and a fun session together. All right. Thank you, team. Thank you, coders, for letting me know that the mic is good. So let's begin by reading out the copyright, CPT copyright 2026. American Medical Association, all right reserved. CPC is a registered trademark of AAPC, and the AAPC content found within this presentation is a copyright of AAPC. The keyword concept FTR, CHON, AMCI FAB 7, AMCI ICD 10, Flip, TAP, and MCG are the trademark of AMCI. The credentials CPC, CRC, COC, CPMA, CPB, CPPM, CPCO are owned by AAPC. AMCI do not own right to these credentials. The credentials CCA, CCS, CCS-P, RHIA, RHIT are owned by AHIMA, and AMCI do not own right to these credentials. All right. So today we will be covering some topics, some of the CPT topics that are frequently tested on the exam and most commonly used in real world coding as well. Yes, I am talking about the excision and or resection procedures from the soft tissue tumor. All right. Okay. So excision and resection of the soft tissue tumors, as well as the introduction or removal procedures. These both are from the musculoskeletal system, and we have also nasal and sinus endoscopy, as well as the lung transplantation procedure coding, and they are from the respiratory system. All right. So we will be covering these four topics. So let's kick the things off with the musculoskeletal system topics, and we will be first going through the excision and resection of the soft tissue tumor guidelines. So you will notice that these procedures are not just in one place. Instead, you will find them organized under each anatomy section like head, neck, and other anatomical areas. So they applies to the all these areas. And now today we are generally going to go through the general guidelines. Yes, so let's talk about the excision and resection of the soft tissue tumor, starting with the definition, because this is where the students usually get tripped up. And these procedures, as you can see, are divided into four categories, and this division is based on three factors. One, the depth of the tumor. Two, what tissue is involved, and how aggressive the tumor is. So first the excision. First let's look at the excision of let's look at the excision of soft tissue subcutaneous connective to subcutaneous soft tissue connective tumors. All right. Okay, I tripped a little bit over the these tumors are confined to the subcutaneous tissue. As you can see in the image over here, these are confined to the subcutaneous tissue, meaning they are below the skin but above the deep fascia. You can see it's just below your cutaneous layer and it's above the deep fascia as well. Next, let's look at the excision of the facial or subfacial tissue tumors. Over here, yes, let me point it out. All right, here the tumors are located within or below the deep fascia, but they do not involve the bone, and they are usually benign in nature and often intramuscular tumor. So you can see it's located within the muscle, so it's a intramuscular tumors which are removed under this category. And they also involve the digital subfacial tumors. So you can see over here the other picture, the digital subfacial tumors, and they are generally means they are the finger and toe tumors. So these tumors involve the tendon sheath, and the joints of the digit. So if the tumor actually involve the tendon sheath and or joint, it is considered as a subfacial tumor. However, if the tumor is only touching or sitting next to the tendon or tendon sheath or the joint, but does not breach them, then these tumors will be considered as subcutaneous soft tissue tumors. So that is a very important point while coding the digital tumors, right? So keep a note of that. And let's move on to the next category, that is for the radical resection of soft tissue tumors. Yes. Okay. So the radical resection of the soft tissue tumors here, even if the tumor is confined to one layer like subcutaneous or subfacial, the radical resection require removing the tissue from one or more layers. Yes. So these are mostly performed on the malignant tumors or very aggressive benign tumors. So you can see coders here. The tumor might be maybe originally in one of the layers, and then it might extend to the another layer. That's what we were talking about. So it might involve more than one layer. And that is the situations or the scenarios when we require a radical resection of these tumors. And finally, let's move on to the last category. Yes, that is for radical resection of bone tumors. And in these cases, the tumor growth may be so extensive that it requires removal of the entire bone, such as a clavicle, for example. And here also, the radical resection of the bone tumor is typically performed for malignant tumors or very aggressive benign tumors. So remember coders, deeper and more aggressive the tumor, more the resection, extensive resection required. All right. So we have done with the definition. Now let's look at the guidelines. Let's start with the common CPT guidelines that apply for all of these four tumor excision or resection categories. Okay, so we are going to look at the guidelines which is common for every four or each four categories. And the first rule is that simple and intermediate repair are included. Okay, that means your routine closure is already bundled into this code. Now, the second rule states that complex repair, however, may be reported separately, but only when it is clearly documented. So, what qualifies for a complex repair? The things like extensive undermining or advanced closure techniques. Those are the keywords. So whenever you see an extensive undermining and advanced closure technique, that qualifies for a complex repair for this section. And the third common rule is that any dissection or elevation of the tissue planes needed to reach the tumor is already included. So just getting down to the tumor doesn't earn you extra codes. All right. And the fourth rule, this if the surgeon performs significant vessel exploration or neuroplasty, that work may be reported separately, again only when it truly uh it is correctly documented. All right. So next, let's talk about the rules or the guidelines that apply to the first three categories. Okay, so these are the common rules that apply to the subcutaneous soft tissue resection, facial or subfacial soft tissue tumor resection, and radical resection of the soft tissue tumor. So here the code selection is based on the size and the location of the tumor. So how is size calculated? So size is calculated by measuring the greatest diameter of the tumor plus the margin required for the complete excision of the tumor. So yes, this is the same formula which we used for the excision under the integumentary category, right? Okay, so that same formula you can use for the excision of these three tumor resection categories. Now, when dealing with the bone tumor, CPT makes one thing very clear. Your code choice is based on the location, all right, and not on the basis of the size or not on the basis of the margin. And this procedure involves removing of the bone tumor with wide margin, and they are most commonly done for malignant tumors or very aggressive benign tumors. And depending upon how extensive the tumor is, the surgeon may remove the part of bone or the entire bone, like a clavicle, as I said before. And now, here, really important bundling rule is that if the surgeon removes a surrounding soft tissue during a radical bone resection, you do not code for the soft tissue tumor resection separately. It is already included. All right. Okay, so let's move on. And next, let's move to the next musculoskeletal topic, the introduction and injection procedures. So this section focuses on the procedures where something is introduced or removed from the musculoskeletal system, such as it can be an injection, it can be aspiration, it can be needle insertion as well. So you will again here also notice that these procedures are organized based on the anatomy involved. All right, and here we are going to look at some of the general codes and the general guidelines involved. So let's look some of the CPT codes under this section quickly. We have CPT code 20500, that is for injection of sinus tract, therapeutic. At the same time, we have 20501, that is for injection of the sinus tract, diagnostic. So that is the difference between these two codes. Next, we have code for the removal of the foreign body from the muscle or tendon sheath. If it is simple removal, you use 20520, and if it is a deep or complicated, you will use 20525. Then we have 20526 for injection therapeutic carpal tunnel. So that is mainly used for the patients with the carpal tunnel syndrome, where injection of a steroid might be given to the carpal tunnel. All right. And we have 20527, that is for injection enzyme to the palmar facial cord. Also, we have 20550 over here. That is for injection single tendon sheath or ligament or aponeurosis. And we have 20551. That is for injection tendon sheath origin or insertion. Now, next, we are moving on to another important code series. It's about the trigger point injections. And before that, let me explain what a trigger point is. Trigger point is a small, localized, hyper irritable spot within a muscle. In simple terms, this is a tight knot in the muscle that hurts when you press on it. And a trigger points can cause local pain, referred pain. So what's a referred pain? Referred pain means the pain that shows up somewhere else. All right. And we have muscle stiffness associated with these trigger points as well. So often trigger points are associated with things like myofascial pain syndrome, chronic muscle strain, etc. And trigger point injection is given, as you all know, to relieve the muscle pain and spasm, also to improve the range of motion and to reduce the inflammation. So while coding the trigger points, we have only two codes under trigger point injection. And while coding these injection, you have to keep in mind of these important coding guidelines. First, trigger points codes are selected based on the number of muscles treated and not based on the number of injection. And second, remember, one muscle can contain multiple trigger points. Third point, even if the provider performs multiple injection into the same muscle, it is still considered as one muscle for coding purpose. All right. And finally, the image guidance. If an image guidance is performed, CPT directs you to report appropriate image guidance codes such as 76942, 77002, and 77021. All right. So that is about the trigger point injection. And you have to be a little bit forensic while coding these codes. So next we have the code 20560, where the provider, typically this is used by typically by the physical therapist or physiotherapist, who inserts a needle without medication into the trigger point. All right. So we have those codes. We have 20560 and 20561, depending upon the number of the muscles. And also we have 20555, 20555, which is used for placement of the needle or catheters into the muscles and soft tissue for subsequent interstitial radiation radio element application. Okay, now let's move on to the next important codes under the introduction and injection series. They are arthrocentesis codes, arthrocentesis aspiration or injection codes. Now, let's talk about arthrocentesis. It is also known as a joint aspiration. So, arthrocentesis is a procedure where the physician uses a needle to enter a joint and withdraw the synovial fluid. So this is usually done in a swollen or painful joint such as knee, shoulder, or elbow. And there are two main reasons arthrocentesis is performed. It can be done due to for a diagnostic reasons and for the therapeutic reasons. So diagnostic reason, arthrocentesis really helps to determine the cause of the joint pain or the swelling by analyzing the synovial fluid for infection, arthritis, etc. And second is the therapeutic reason. So a patient with a swollen knee or a swollen joint, by removing the excess fluid, it relieves the pain and the pressure, as well as it improves the joint mobility. Right. So that is about the arthrocentesis procedure. And let's have a look into the codes for arthrocentesis. So arthrocentesis codes are classified based on two things. First is the type of the joint or bursa. So CPT divides the joints into three sections, that is small joints, intermediate joints, and major joints. So second classification is based whether an ultrasound guidance were used or not. Okay, so let's break it down. So we have small joints or bursa like fingers and toes. In such cases, we use CPT code 20600 when done without ultrasound guidance, and 20604 when done with ultrasound guidance and permanent recording. All right. And next we have the intermediate joint or bursa, such as the wrist, your elbow, ankle, temporomandibular joint, acromoclavicular joint, or I'm sorry, Olencranon bursa. So here you use the CPT code 20605 when done. Arthrocentesis is done without ultrasound guidance, and 20606 when the procedure is performed with ultrasound guidance. And finally, we have major joints or bursa like the shoulder, hip, knee, or subacromial bursa. Here we use 20610 when the procedure is performed without ultrasound guidance, and we use 20611 when arthrocentesis is performed with ultrasound guidance. All right, are we good so far, coders? Let me know in the chat. Now, here is an important CPT guideline. So if the ultrasound guidance is reported make sure that it include the permanent recording and reporting. All right, thank you for letting me know, Zombogirl. And now let's move on to the next topic for the day. And we are going to look into the nasal and sinus endoscopy procedure. This comes from the respiratory system. All right. So, yeah, let's talk about nasal and sinus endoscopy. So, as you all know, most of you must be knowing what a nasal endoscopy is. Nasal or sinus endoscopy is a procedure in which the physician uses the nasal or sinus endoscope to directly visualize the inside of your nasal cavity and the sinus pathway, right? And this procedure usually falls under the category CPT code series 31231 through 31298. So yeah, this is another image for the nasal endoscopy. And one of the first rule you need to remember is that the codes 31233 through 31298 are reported as unilateral procedure unless unless the code description clearly says otherwise. All right, so that is a very important point, and better you chun them as well. Okay, now before we jump into the individual codes, CPT makes an important distinction here whether the endoscopy is diagnostic or a surgical endoscopy. Let's start with the diagnostic nasal and sinus endoscopy. So these codes are ranging from 31231 through 31235. And there is an important guidelines which you have to remember or take a note for these diagnostic nasal endoscopy procedure. And the guideline says that when a diagnostic nasal or sinus endoscopy is performed, CPT expect the provider to use endoscope to inspect all of the following area. That includes your nasal cavity, your middle and superior meters, your turbinates, the sphenoid ethmoid recess, and here is the key CPT rule. When the diagnostic evaluation is performed, all of these areas are considered included, and you do not need to report separate code for each structure examined. And what if all of these areas cannot be fully examined? So again, here also CPT gives us a clear guidance. If the exam is limited and repeat exam is not planned, you would append a 52 modifier. And if the exam is discontinued and a repeat exam is planned, then you will report a modifier 53. All right, coders, that is a very, very important guideline to take note of. Okay, so as I said, diagnostic nasal endoscopy codes they assume or complete exam, and the modifiers are only used when that full exam cannot be completed. Okay, so let's move on, and now let's talk about the surgical nasal and sinus endoscopy. And the code series are from 31237 through 31298. So you can see all these codes that falls under surgical nasal endoscopy. And here is the most important rule to remember. Surgical sinus endoscopy already includes your diagnostic endoscopy as well. And CPT also tells us that surgical sinus endoscopy includes a sinusotomy when appropriate, and that work is built right into the surgical code. Now, another point is that now while when coding for a balloon sinus dilation, and these codes are belong to 31295 through 31298, and these codes include the fluoroscopy. So if a fluoroscopy is performed along with the balloon sinus dilation, you would not code them separately. Okay, so that's all about the endoscopy guidelines. And the final topic for the day, from the respiratory system, it is going to be about the lung transplantation procedures and the guidelines associated with it. So CPT tells us that a lung allotransplantation involves three distinct components of the physician's work. So if you understand these three parts, codes make sense and they are easy. So the first component is the cadaver donor pneumonectomy, and this is reported with the CPT code 32850. And this includes the harvesting of the donor lung, cold preservation of the allograft as well, and perfusing with the cold preservation solution, also the cold maintenance. So all these procedures are included in your cadaver donor pneumonectomy code, that is 32850. Okay, so everything related to removing and preserving the donor lung is bundled into 32850. Second component is the backbench work. So this work happens outside the body before the lung is implanted. So if a single lung is prepared, you use 32855, and these codes includes dissecting of the lung to prepare for the pulmonary venous or arterial cuff and pulmonary artery, bronchus as well. So if only one lung is prepared, you will use 32855. If two lung is prepared, you will use 32856. And finally, the third component, that is recipient lung allotransplantation. And this is actual transplantation into the patient's body, and it includes the care of the recipient as well. And the CPT code here are 32851, which is used for a single lung transplant without cardiopulmonary bypass. Then we have 32852, that is for single lung transplant with cardiopulmonary bypass. So the only difference between these two codes is whether it's performed with a cardiopulmonary bypass or not. And then we have 32853 and 854. They are also for, both are coding for double lung transplant, and 32853 is for a double lung transplant without cardiopulmonary bypass, while 32854 is for a double lung transplant with cardiopulmonary bypass. All right, Coda. So it's a small topic, but as I said, you have to be forensic. You don't should not miss out on any of these guidelines. Okay, so let's do some coding exercise on all of these four topics which we discussed today. Are you ready? Are you ready, Coders? Let me know in the chat. Okay, great. Let's begin with exercise number one. Here we go. Of the following answers, which best describe the procedure? Your options are option A 20600RT, option B 20611RT, option C 20605RT, option D 20610RT. A 52-year-old patient presents with the pain and swelling of the right knee due to inflammatory arthritis. After evaluating the patient, the provider determines that an arthrocentesis with injection is medically necessary. The physician prepares the right knee using sterile technique and inserts a needle into the knee joint. Synovial fluid is aspirated, followed by injection of corticosteroid. No ultrasound guidance is used during this procedure. All right, coders. Now you have to code for the arthrocentesis procedure performed here, and your time begins now. I'm sure you don't need 2.5 minutes to answer this one. Give your best answers, coders. Go ahead. You are going to rock this scenario, I'm sure. All right. So you didn't need that 2.5 minutes at all. So if anyone is working on them, please continue. And don't be afraid to put your answers in the chat. We are all we are all learning here together, right? And let's go ahead and let's solve this one. Okay, so in the inventory we have a right knee arthritis patient with a right knee arthritis, and okay, let me get this banner down. Okay, so we have a patient with right knee arthritis, and right knee arthrocentesis is a procedure performed. Now we have all of our four options here. All the four are for arthrocentesis procedure. All we have to do is to find the correct CPT code, find the uh, correct location, right? We have a right knee arthrocentesis, and 20600 is coding for an arthrocentesis of or aspiration or injection of the small joint. And you have all your examples over here. It includes your fingers, toes. We had an arthrocentesis performed on the right knee, and it doesn't falls under this category. So straight away that is a wrong answer. It's not a small joint. Next, let's have a look into 20605. That is for arthrocentesis procedure performed on your intermediate joint. Again, you don't have your right knee or your knee in these examples. So that is also wrong. So knee doesn't falls under intermediate joint category. So it is also wrong. And finally, we are left with option B and C. Option B is coding for 20611 and D is for 20610. So let's have a look. So 20610 is for arthrocentesis, aspiration, and injection of the major bursa. And you can see the knee, your knee is over here. Yes, over here in the examples. And 20611 is coding for an arthrocentesis of the major joint, including your knee, with ultrasound guidance. Now we know that there was no ultrasound guidance used for this procedure. It's well documented, so it's not going to be 20611, it is going to be 20610 with an RT modifier. All right. Hi, so we have someone over here. Hello, welcome to the class. So, yes, okay. So go ahead, Chorus. Okay, great answers. So let's move on to the next one. Here we go. Second question. Of the following answers, which best describe the procedure? Option A 20605, option B 20610, option C 20612, option D 20600. A 45-year-old patient presents with a painful, palpable ganglion cyst on the dorsal aspect of the right wrist that has not responded to the conservative treatment. After evaluation, physician decides to perform aspiration of the ganglion cyst, and using sterile technique, the needle is inserted directly into the ganglion cyst and a gelatinous fluid is aspirated. No imaging guidance is used during this procedure. Of the following answers, which best describe the procedure? What say you, coders? And your time begins now. All right. I thought that might trick you, but you all are amazing and you got it spot on. Great job, coders. Great job. So, what is the procedure performed here? First question, that would be my first question. We have in inventory a patient with a right wrist cyst and an aspiration of the ganglion cyst at the right wrist is performed. So, is this an arthrocentesis procedure? Let me know, coders. Let me know in the chat. Okay, I would say this is not an arthrosynthesis procedure. We have an aspiration of the cyst perform, the ganglionic cyst perform, not from a joint, right? Even though the cyst was on the wrist, it was a ganglionic cyst aspiration that is performed. So it is not going to be any of these arthrosynthesis code. So it's not 20600, which is for an intermediate, or no, it's for a small joint arthrosynthesis. It's not right. It's not going to be 20605. It's not going to be 20610. The correct answer, as you all said, is going to be 20612. That is for an aspiration and or injection of the ganglionic cyst, any location. Right? So that's also important. Any location. Great job, coders. You all are rocking it in the chat. Let's quickly move on to the next one. Exercise number 3 of the following answers which best describe the procedure. Option A 20552, option B 20553, option C 20553 times 2, option D 20552 times 5. A 40-year-old patient presents to the clinic with chronic right upper back and shoulder pain. On examination, the provider identifies palpable trigger point in the right trapezius and the right rhomboid muscles. After obtaining informed consent, the skin is cleansed using sterile technique. The physician injects 3 trigger points in the right trapezius muscles and 2 trigger points in the rhomboid muscle using a mixture of local anesthetic and corticosteroid. No imaging guidance is used. And of the following, which best describe the procedure? All right, coders, give your best shot. Yes, you are all on fire. So this is this is another scenario where you have to apply those guidelines which you learned just a couple of minutes before. So let's start with looking at the inventory. So here we have a trigger point in the right trapezius and right rhomboid muscles, and let's have a look into the injections which has been given. So in right trapezius we have two trigger point injection given, and the right rhomboid we have three trigger point injection given. All right, so these are the muscles, the right trapezius and right rhomboid. They are the two muscles, and these two muscles had two trigger points in the right trapezius and three trigger points in the right rhomboid muscle. All right, so let's have a look into the guidelines before we start coding this scenario. Guideline number one, as I said, you have to code for the number of muscles and not for the number of injections. Guideline number two, one muscle can contain multiple trigger points. As you can see, it's clear from this scenario. You have right trapezius with two trigger points, right rhomboid with three trigger points, and multiple injection on the same or into the same muscle still count as one muscle for coding purpose, right? So let me know in the chat, coders, how many muscles were injected, or on how many muscles were trigger point injection given in this particular scenario. Let me know in the chat. What do you think? Okay, great. Any other answers? Yes, yes. You all are right. Yes, we have only two muscles, right? Yeah, we had only two muscles. One is your right trapezius and the other is your right rhomboid. And 20553 is coding for injection, single or multiple trigger points to the three or more muscles. Am I right? So we have only two muscles, as you all are saying in the chat, not three muscles. So that makes option 20553 incorrect. Your option B is incorrect, and your option C is also incorrect. So those two are incorrect. So there you go, option B and option C. Now we are left with option A and option D. Both are coding for the same CPT, that is 20552. Now 20552 is for injection, single or multiple trigger points, one or two muscles. And option D is coding for 20552 times 5. Now do we have to code that times 5 here? No, right? We are coding for the number of the muscle injected, not for the number of injections, not for the number of trigger point injection. And that makes option D incorrect. And the correct answer is going to be 20552, which is option A. All right, coders, let me know in the chat. Let me know in the chat. Did the explanation help? As we had mixed answer for this scenario, so let me know in the chat, please. Did the explanation help, or do you need any more explanations or assistance? Let me know in the chat. Our team is in the chat as well, so they're also going to help. Great. Thank you for letting me know. Let's move on to the next one. Here we go. Exercise number 4. Of the following answers, which best describe the procedure? Option A 31231, option B 31238, option C 30903, option D 31231, 31238. The 59 modifier. A 60-year-old patient presents with a persistent epistaxis unresponsive to the conservative measures. After evaluation, the physician performs a diagnostic nasal endoscopy. Using endoscopic visualization, an actively bleeding vessel is identified in the right nasal cavity. The physician performs the endoscopic cauterization to control the hemorrhage. Bleeding is successfully controlled. Of the following answers, which best describe the procedure? Because your time has already started. All right, Curtis, that is time. And I see that you all took some time, a while to answer this one. So you were all thinking, that is great. That is great. So the response was not quick for this one. So it's a good scenario, right? So you had to think which guideline to apply. So we have here 30903 CPT code, which is for control of nasal hemorrhage anterior complex, any method. So yes, there was a nasal hemorrhage and a control of a nasal hemorrhage was performed, but 30903 is incorrect because we had an endoscopic approach used, right? Nasal endoscopy was performed and an endoscopic control of the hemorrhage was done, right? So that's the reason why 30903 is incorrect. C is wrong. And let's look into the next code. 31231. This is for a nasal endoscopy, diagnostic unilateral or bilateral. Sorry, bilateral. Okay, now this one is for a diagnostic nasal endoscopy. Did we have a diagnostic nasal endoscopy performed here, Codus? What do you think? Let me know. Let me know in the chat. Yes, it was mentioned that physician is going to perform a diagnostic nasal endoscopy. But if you completely and forensically read the scenario, you can see that endoscopic visualization was done. And physician realized that there is an actively bleeding vessel during that evaluation. And he performs an endoscopic authorization, right? So that becomes a surgical endoscopy. Yes. So that makes it a surgical endoscopy. That is a reason why we have to read the scenario carefully and not just go by what was planned. So always something might change during the procedure. So always be forensic. That's why we are the best medical coders, right? We have to read the entire scenario, whether it's a surgical note or not. We have to read that operative report and find out whether other procedures were performed or whether the planned procedure was performed. So here we see that yes, there was a surgical intervention performed, and from the guidelines, you know that the diagnostic endoscopy procedures are included into the surgical endoscopy procedure. And this is not a separate procedure, right? This is not going to be a separate procedure. So option 3A 31231 is incorrect. Also option D 31231 and 31238 with the 59 modifier is incorrect. As we said, the diagnostic endoscopy would be included or bundled into this surgical endoscopy procedure. So that makes option D wrong, and the correct answer is going to be option B 31238. That is for nasal endoscopy, diagnostic, unilateral or bilateral. Sorry, nasal endoscopy, surgical with the control of hemorrhage. All right, Curtis, what do you think? How do you feel now? Better after the explanation? Okay, great. I think that was aha moment for some of you. All right, all right. Great job. So let us know if you have any doubt. We are here to help you. So quickly, let me move on to the next scenario exercise number 5. Of the following answers, which best describe the procedure? Option A, 32850, option 32853, option B 32850, 32854, option C 32850, 32856, 32854, option D 32850, 32856, 32853. A 52-year-old patient with end-stage pulmonary disease is scheduled for a bilateral lung transplant. A suitable cadaver donor is identified after donor procurement. The transplant surgeon performs cadaver donor pneumonectomy, harvesting both lung and placing the allograft in cold preservation solution. The patient is then taken to the operating room where the surgeon performs bilateral lung allotransplantation, implanting both donor lungs and providing care for the patient. Of the following answers, which best describe the procedure? I can see some answers are already in the chat. Okay, your time begins now, Codis. All right, Codis. All right. So let me walk you through this scenario. So we'll code this together, and let's do the inventory first. So we have a bilateral lung transplant procedure performed, and the first step is your cadaver donor pneumonectomy. Yes, cadaver donor pneumonectomy was performed. You can see after the donor procurement, the transplant surgeon performs a cadaver donor pneumonectomy. So that was clearly documented. What is going to be the next procedure? Next documented procedure says that a bilateral lung allotransplantation was performed, right? So the cadaver pneumonectomy, after cadaver pneumonectomy, harvesting of the lungs was done by placing the allograft in a cold preservation solution. So placing this in a cold preservation solution, it's already included in your donor pneumonectomy code, right? And after that, the surgeon performs a bilateral allotransplantation procedure. So was there any backbench work documented in this scenario? Let me know in the chat, coders. Was there any backbench work performed? No, right? There was only a pneumonectomy and a low transplantation done. That's why I put in the banner B forensic coder. Sometimes you might miss out something. So 30850, that is coding for a pneumonectomy, including your cold preservation. So that is included in the pneumonectomy procedure. So yes. And then we have 32856, which is for a backbench work. It was not done, so I can eliminate option C and option D straight away. No backbench work was done. We left with option A and B. So option B is coding for 32854, and option A is coding for 32853. 32853 is for lung transplant double with cardiopulmonary bypass, and 32854 is for lung transplant double with cardiopulmonary bypass. So this procedure was done without a cardiopulmonary bypass, which eliminates option B. And the best possible answer is option A. I can see a lot of people are changing, and I also saw an aha moment. So excellent job, coders. So P forensic. These are small topics, but P forensic so that you will get it right. Okay, let's move on. I have one more scenario. Let's move on to the next one. All right. Of the following answers, which best describe the procedure? Option A 26115, option B 26111, option C 26113, option D 11402, 12041 with a 59 modifier. A 46-year-old patient presents with a small, painful mass on the palmar aspect of the right index finger that has been gradually increasing in size. On examination, the provider identifies subcutaneous soft tissue tumor measuring 1.2 centimeter. After obtaining informed consent, the area is prepped and draped in sterile fashion. The physician performs excision of the subcutaneous soft tissue tumor of the finger, removing the lesion in its entirety. The tumor measures less than 1.5 centimeter and the wound is closed in layers. Okay, coders, your time begins now. I'm sure you will place answers before 2.5 minutes and then we will review it. All right, so I have a few answers in the chat now. It's almost time. So someone has asked about. I think it's about the previous scenario. So we will be coding what's documented, right? So as coders, it's our responsibility to code as per the documentation. If anything is needed, we definitely can query the physician. That would be in a real world coding, but for the exam, definitely go for or go code as per the documentation. All right. So I hope that helped. And let's solve this scenario. Okay. Answers are coming. Okay. This is what we have here in the inventory. We have soft tissue tumor, right index finger, and 2026113, it's coding for excision of a tumor of a soft tissue or vascular malformation of the hand or finger subfacial, right? Okay, yeah, that is for a subfacial excision. And codus, we have a soft tissue tumor of a subcutaneous origin. Yes, it's a subcutaneous soft tissue tumor that was documented, and the excision also was for a subcutaneous soft tissue tumor. So it's not a subfacial or intramuscular tumor excision that was performed. That eliminates option C. And we are looking into the next one, 11402, which is for excision of benign lesion, including the margins except the skin tag, trunk, arms, legs. Excise diameter is 1.1 to 2 centimeter. Now, again, this is for excision of cutaneous origin, right? The benign lesions of cutaneous origin. We had an excision of a soft tissue tumor, and you can see it's also documented over here that for excision of benign lesions of the cutaneous origin, you have to use the code series from 11420 through 11426. So this is not a cutaneous lesion. We are coding from musculoskeletal chapter because it was a subcutaneous soft tissue tumor. Okay, now between option A and option B, option A is coding for 26115 and option B is coding for 26111. So the parent code states that excision is for excision of the tumor or vascular malformation, soft tissue of hand or finger, subcutaneous. Now, this is a correct code selection. It's of a subcutaneous level, and excise size is less than 1.5 centimeter, while 26111 is for excision of 1.5 centimeter or greater. And if you read the scenario carefully, you will see that the tumor measure was less than 1.5 centimeter, and that makes option B incorrect, and the correct answer is going to be option A. So fantastic job everyone, you all did a good job in this. All right, so let's have a quick. I have only three questions for the polls today. Let's have a quick hand poll and let's see how much you remember the guidelines which we learned today. All right, cool. This is a rapid fire. You all know the drill. Here we go. The question: how should the fluoroscopy be reported? Option A, report fluoroscopy separately. Option B, report the fluoroscopy with a 26 modifier. Do not report the fluoroscopy separately. Option D, report the fluoroscopy with a 59 modifier. All right, a patient undergoes balloon dilation of the right maxillary sinus ostium. Fluoroscopy is used during this procedure. What say you, coders? Now, I read the question very fast, and you got to place the answers very fast as well, because this is a rapid fire scenario. All right, callers, what say you? What say you? What say you? Remember the guidelines which we learned just right now? Answers are coming. Answers are coming. Way to go, Zombo girl. Yes. And the correct answer is do not report fluoroscopy because it is already included here, right? So the code series 31295 to 31298, as I said, they describe the dilation of the sinus ostia by the displacement of the tissue. Any method includes a fluoroscopy if performed. So great job. Let's move on to the next one. Which modifier should be appended? Modifier A, option A, modify 53, option B, modify 59, option C, modify 52, option D, modify 50. A diagnostic nasal endoscopy is performed, but not all required areas can be examined, and no repeat examination was performed. Which modifier should be appended? What say you, coders? Let me know in the chat. Which modifier would you append in this scenario? All right. All right. Okay. Okay. Everyone's catching up. And the correct answer, yes, absolutely correct. You would use a 52 modifier, right? And there you go. Here is your guideline. Excellent job. Let's move on to the next one. Okay. Trigger point injection. CPT codes are selected based on the number of injection performed. Is this statement true or false? All right. All right. Okay. Okay, now once again, chat is on fire. It is, yes, it is indeed. It is false, right? Trigger point injections are based on number of the muscles injected, not based on the number of injection. So you all nailed those guidelines. You all have learned a lot today. Yes, Miss Rosa, spectacular. Amazing job, Curtis. All right. So, with that, I think we come to a conclusion of this week's CPT guideline mastery. So, survey link is already in the chat. Coders, please go ahead and please let us know how was the class, how was the session, what you like to listen more. So next week probably we'll be coming up with a cardiovascular system topic. So if you enjoy the video, go ahead, please smash that like button, subscribe. I know you, most of you have subscribed. Share it with someone who needs to see this. All right, so please coders, please go ahead and like this video, as well as please fill the survey form. Okay, so we'll see you all next week with the cardiovascular system topic. Till then, stay safe, keep coding. We'll all see you next week.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around.